Good evening, friends. As suggested by Dr. Vijay Goswami, this time I am recording with a external mic for a better quality of sound. Hope this will be helpful. And today I am going to talk about tap block. First of all, I will like to wish all of you a very happy Diwali and a very prosperous New Year in advance. This was my presentation at Baroda Visakon recently in 2019, 11th and 12th October. So now I am recording it for all of you. I believe this will be helpful to understand what is a tap block and how to do it. So if I talk about tap block, it is a very simple but very effective block. There are many myths regarding tap block. We will say that it is not that effective, analgesia is not that good, it is not that consistent. But if you know how to do it, it is a very simple block and very effective too. There is lots of confusion about tap block. First of all, important confusion is about various type of block like subcostal tap block, lateral tap block, lower or ilioinguinal iliohypogastric nerve block in tap plane, and last but not least posterior tap block. So these are the various tap blocks described in literature. These are different blocks at different level, and if you know the anatomy and know the indication, then only you will give right type of tap block, and you will get postoperative analgesia for the patient. So there are many myths and misunderstanding about tap blocks, like tap block is done with ultrasound only. This is the biggest myth. Many people believe that it is done with ultrasound only, but you can do it with landmark guided technique. You can do it with PNS guided technique that is described by Dr. Surjit Giri. You can do it with ultrasound also. There are various approaches with which you can give tap block with equal efficiency. Second biggest myth is you need a linear probe to give tap block. Yes, usually it is given with linear probe only because it is a bit superficial block. In obese patient, sometimes you require curvilinear probe. Otherwise, in more than 90% of the patient, you can give it with a linear probe with some application of pressure. But even if you don't have linear probe, and if you curvilinear probe or transvaginal probe, you can use it to give tap block, and I will show you how to do it. Failure rate is high. This is again a big myth. If you know how to give it and when to give it, then you can bring down the failure rate like anything, and your tap block will work in your 90 to 95% of the patient, and it provides analgesia for 8 to 18 hours, and sometimes I have seen up to 36 hours patient doesn't complain anything, and it is without any additives. Can we do surgery solely under tap block? No, you cannot do surgery alone under tap block, because this is for somatic analgesia. This doesn't cover visceral pain. If we don't understand this, then you will feel that your block is failed, because visceral pain is not covered with tap block. And if you don't give some other analgesic like NSAIDs or paracetamol or tramadol, then patient will complain of visceral pain, and you will start thinking that your block has failed, but actually it doesn't. It hasn't failed. It is because of lack of understanding that you believe that your block is failed. Basically, tap block is a part of multimodal analgesia, and if you combine with some analgesic, patient will be happy, there won't be any pain, patient will be mobilized early, so there are less chances of any DVT or any complication, and the patient can be discharged home early also. So if we look at the anatomy, first of all of us know that abdominal wall is supplied by T6 to T12 and ilioinguinal and iliohypogastric nerves. And there are three muscles of the lateral abdominal wall, that is external oblique, internal oblique, and transverse abdominis. And in midline you find another muscle, that is rectus abdominis muscle. So if you look at the nerve supply, these are the nerves T7 to T12. They come out of the intercostal space. After coming out of the intercostal space, these nerves travels in the plane between transverse abdominis muscle and internal oblique muscle. They are not actually nerve. That is, it is a plexus like thing. It forms a plexus. They are nerve fibers, not exactly the nerve, and they travel between the transverse abdominis and internal oblique muscle, and they supply at different level. So if you first look at the T7, T8 and T9 here, you can see these nerves enter the tap plane, and this is anterior axillary line, this is mid clavicle. So these nerves enter the tap plane anterior to the anterior axillary line. So if you want to block T7, T8 and T9, that supplies the abdomen above umbilicus. If you want to block those nerves, you have to give subcostal tap block. So it is just below the subcostal, it is just below the costal margin and in the tap plane. How to give it, we will see in the next slides. Next is the lateral tap block or conventional tap block. So if you want to block T10 to T10, T11 and T12, then you have to inject the drug in the roughly in the mid axillary line, because these nerves enter the tap plane somewhere there. So if you go in the mid axillary line between costal margin and iliac crest and inject the drug in the tap plane, then it becomes your lateral tap block, and it will block T10, T11 and T12 consistently, and sometimes ilioinguinal, iliohypogastric, and sometimes also T9. So with that, you can give analgesia in the lower abdominal surgery below umbilicus. Third block is ilioinguinal, iliohypogastric nerve in tap plane. This is for lower abdominal incisions like fenestral incision for LSCS or incision for hernia. So for this incision, you have to go just above the iliac crest or palpate the anterior superior iliac spine, go 5 cm cranial, go 5 cm lateral, and go in the tap plane and inject the drug, and both the nerve, ilioinguinal and iliohypogastric nerve, travel in this plane. So with single injection you will block both this nerve. Suppose it is for LSCS, then you have to give bilateral block. Suppose it is for right sided hernia, then give right sided tap block only. But again, always remember this block is for somatic pain relief. For visceral pain you require some another analgesic agent. So if you remember this, you will never fail. Posterior tap block or conventional tap block was with was in the Petit's triangle. We will see in next slide where to give it and how to give it. So if you look at this video, this is external oblique muscle, this is your internal oblique muscle. I am removing the internal oblique muscle, and you can see all these nerves. This is T9, T10, T11, T12 and ilioinguinal, iliohypogastric nerves. Again, this is transverse abdomen and this is ilioinguinal nerve. This is iliohypogastric nerve. So it is just above the iliac crest. So here you can block those nerves. If you want to block T9, this is T9. We will see it. So this is internal oblique, transverse abdominis muscle, and this is your T9 spinal root. So this is in the subcostal area. So for that you have to block this. This is rectus abdominis, and if you remove it between transverse abdominis and rectus sheath, you will find T7 and T8. So that makes your subcostal tap block. So these are various type of tap block, and according to the type of surgery you have to select it. So there are different technique like LOR technique and ultrasound guided technique. If I show my data in the last 2-3 months, here you can see my 63% of the cases are with ultrasound guided technique, while 36% are with landmark guided techniques. So these are the data of tap block. So how to give LOR tap block? Conventionally it was described in the triangle of Petit. So you have to mark the posterior border of external oblique, anterior body or of latissimus dorsi. This is iliac crest, and you have to go in this triangle and feel for the two pops and inject the drug. Here it was believed that drug was spreading in the quadratus lumborum plane and then to thoracic paravertebral space. So with larger volume, with this technique, author was able to give analgesia and above umbilical incision also. This was basically because of spread of the drug in the thoracic paravertebral space or the sympathetic blockage in the quadratus lumborum plane, and this, I believe, this is the base for the quadratus lumborum block. But you have to understand how to give it with a LOR technique, then only you will be successful, otherwise you will fail. And it was nicely described by Dr. Shiv Kumar Singh and et al. In a literature that with name given cushion effect. So what is cushion effect? Here you can see this is a patient, this is external oblique muscle, this is internal oblique muscle, this is transverse abdominis, this is subcutaneous tissue, and this is skin. So when you insert a blunt tip needle, you use a blunt tip needle when you are giving a tap block to fill the pops. So when you insert a blunt tip needle, you will not be able to pierce the skin easily because needle tip is blunt. So you have to apply pressure. When you apply pressure, subcutaneous tissue will be compressed like a cushion, and when it pierces the skin, suddenly it will give away and it will pierce skin along with external oblique fascia. So your first pop will be lost because you have to apply too much of pressure. Along with skin, you will pierce external oblique fascia and you will end up going in the internal oblique fascia when you feel first bounce and pop. So with first bounce and pop, you pierce internal oblique fascia, and with second pop, you are below the transverse abdominis muscle. So you are in the wrong plane. When you inject the drug here, your block will not act. So you are in the wrong plane. So how to prevent this cushion effect? There are simple techniques. First is insert the needle parallel to the skin. So remain parallel to the skin first, pierce the skin, then make it perpendicular to the skin, then advance the needle, fill the pop, bounce of the external oblique fascia, fill the pop of external oblique fascia, advance the needle, fill the bounce of internal oblique fascia, fill the pop of internal oblique fascia, and then inject the drug, and you are in the right plane below the internal oblique fascia, and here you will block the nerves and your block will act. So if you understand this concept, then you will never fail. So again I will show how to do it. This is in the wrong plane. Insert the needle parallel to the skin, make it perpendicular, fill the bounce of external oblique fascia, fill the pop, fill the bounce of internal oblique fascia, fill the pop, and inject the drug in the right plane. So this is how you can give tap block with LOR technique. If it is conventional or lateral tap, then go between costal margin and iliac crest in the mid axillary line at the midpoint. Fill the toe pop and inject the drug for lower abdominal surgery below umbilicus. If you want to block ilioinguinal iliohypogastric nerve in tap plane, palpate the anterior superior spine, go 5 cm cranial, go 5 cm lateral. It will be just above the iliac crest. Again fill the toe pop and inject the drug. If you want to give subcostal tap block, draw the anterior axillary line, go 3 cm medial to it, fill the pop of external oblique fascia and internal oblique fascia and inject the drug. That becomes your subcostal tap. So with two pop technique, you can give any of the tap block. So there are certain other method to prevent the cushion effect, like make an incision in skin with step knife so that you can pierce the skin easily, and then you can feel the pop of external oblique and internal oblique fascia. Needle through needle technique, you can use pencil point needle where external needle has sharp tip, so you can easily puncture the skin, then advance the needle through it to feel the pops. withdraw the needle up to the skin after inserting it, and I use it regularly. You can use various needle like Tuhi needle, which is blunt tip. You can use pencil point needle as I described, blunt tip block needles, and last but not least, you can use hypodermic needle or spinal needle in obese patient to give the block. So you require just a needle, syringe, and local anesthetic drug to give tap block. So how to blunt the needle tip? It is very simple. This is a ball of the local anesthetic, and I will hit the needle twice or thrice to blunt the needle tip. So here you can see this is LA bowl, and I hit the needle twice or thrice, and my needle tip has got blunted. So this is how you can blunt the needle tip. Another technique I will show, and this is another technique, two needle technique. Needle through, this is 18 gauge needle, this is 21 gauge needle, which I want to give the block. So how to blunt it? You have to insert the needle in the another needle, and you can make a parrot beak of the needle, and you can use it. So there are various type of technique. You can use ampule inside of the ampule to blunt the needle tip. You can use technique of your choice, make the needle tip blunt, and then use it for giving the tap block. If patient is obese, use the spinal needle. So how to give a lower tap block? This is very simple. This is landmark guided tap block. This is post LSCS patient. This is anterior superior spine, which I am palpating. I will go 3 finger or 5 centimeter cranial, from there 5 centimeter cranial, then 5 centimeter lateral, and that is my needle insertion point. Here you can see I am inserting the blunt tip needle. After painting and wrapping, I am inserting the needle through the skin. Here you can see I have kept the finger so that I don't go too deep. So now I am advancing the needle, feeling the bounce and pops of the fascia, first pop, and then feeling the second bounce. This is first pop and bounce and pop, and this is second bounce and pop of the internal oblique fascia. After aspiration, I am injecting 0.25% Ropivac in 20 ml. This is LSCS patient. So I am injecting 20 ml of LA on the both sides. So you can see I have injected 10 ml, and after injecting 10 ml of the drug, I can see the backflow of the drug. If you are in the facial plane, then only you will get the backflow. If you are in the muscle, then you won't find such backflow of the drug. So I am injecting total 20 ml of LA. So after every 5 ml of injection, always aspirate to see the any intravascular injection. There is a branch of this deep circumflex iliac artery in this plane, so be careful. So after giving injection, I confirm with the ultrasound. This is curvilinear probe I put on the injection site, and what I saw here, you can see this is my external oblique muscle, this is internal oblique muscle, and this is transverse abdominis muscle, and this drug is nicely spread in the tap plane, and it will provide excellent analgesia in the postoperative period. So second is the LOR subcostal tap block. Again here I have drawn the anterior axillary line. This is costal margin, and medial to the 2 to 3 centimeter medial to the anterior axillary line is the needle insertion point. This is blunt tip needle. Again I am feeling the bounce of external oblique fascia, then pop, then again I am advancing the needle, bounce and pop. So after 2 pop, I will inject the drug in this plane, and it will become my subcostal tap block. So again I am aspirating and injecting, and this is how you can give subcostal tap block. Ultrasound guided tap block, again it is very easy. These all videos are available on my YouTube channel, and again I am also this is also available on YouTube. So this is my machine. I have selected the musculoskeletal mode because here I am interested in facial plane, so I will not select now block but musculoskeletal mode to give the block. So I have selected the musculoskeletal mode, and now I can see the image on the machine. So first I will scan. I'll put the probe just above the iliac crest, because this is again LSCS patient. This is 100 mm stimuplex needle. This is ropivacaine 0.25%. I put the probe just above the iliac crest, and I will see where the muscles are. So you can see the probe position. Now you can see this external muscle, this is internal oblique, and this is transverse muscle, abdominis muscle, and this is the area where I am interested. This is subcutaneous tissue, this is Kemper's fascia, and this is Scarpa's fascia. So I am inserting the needle in plane, so it will go parallel to the probe, and I can see the entire needle shaft. Here you can see I have pierced the external oblique muscle and filled the probe. Then I am advancing the needle toward the internal oblique muscle, and I will inject the drug in the tap plane. So here you can see now I will start injecting drug. I am almost there. Patient is breathing spontaneously, so in certain image you will see the needle, and in the other image you can't see. So here you can see this is internal oblique fascia, and my drug is nicely spread below the internal oblique fascia, and this block will last long, at least for 12 to 16 hours. Subcostal tap block, again I have to start scanning from midline. This is rectus abdominis muscle, this is beginning of internal oblique muscle. So I will inject 7 ml of LI here to block T7. My needle is coming in plane. Here you can see my needle is coming in plane from medial to lateral. So I will inject 7 ml of LI here. Then I will look for the 3 muscle layer by going little laterally. So here you can see I have started injecting. This is peritoneum, this is internal oblique muscle, and this is rectus abdominis muscle. So here you can see I have started injecting the drug, and drug is spreading between internal oblique and transverse abdominis and rectus abdominis muscle. I am readjusting the needle because I am not happy with the spread of the drug. I want to go exactly in the tap plane. Again I am readjusting. Now you can see this drug has spread, and now I am in the right plane. Here you can see here. Now I am happy with the drug spread. Initially I was not happy, and here you can see 3 muscle, beginning of 3 muscle, external oblique, internal oblique, and transverse abdominis. As I move my probe laterally, you will see it very well. See here, this is external oblique, internal oblique, and transverse abdominis. So after injecting 5-7 LA, I'll go further lateral to block T8 and T9 in the tap plane. So this is for subcostal incisions or above umbilicus incision to provide analgesia along with the rectus abdominis, rectus sheath block. So after giving some drug there, now I am going further laterally in the tap plane here, and I will inject 10 to 15 ml of LA there to complete my block. Here you can see same needle I am advancing between internal oblique and transverse abdominis muscle, and I am injecting the drug to complete my block. Some of the drug has gone between external oblique, internal oblique. Now again I am advancing the needle. Now I am in the right plane. This is a bit older video. I will try to prepare a better video next time. So this is supposed to tap block. This is tap block with curvilinear and transvaginal probe. So again this is transvaginal probe. I have put just above the iliac crest. You can see this is iliac crest, and this is my transvaginal probe, and what I can see is 3 muscle layers. So this is subcutaneous tissue, then external oblique muscle, then internal oblique muscle, and this is the plane I am targeting. So this is internal oblique muscle, and this is transverse abdominis muscle. So this is the plane I am targeting. I am using again hypodermic needle. I will come in plane. I will insert the needle. This is a small footprint probe, so I have to go closer to the probe and insert the needle. Difficult to visualize the needle because of lower frequency and angle of the needle, but you can appreciate the needle movement and drug spread in the tap plane. So this is nicely given tap block with transvaginal probe. Second technique is with curvilinear probe. So on opposite side I am giving with curvilinear probe. I reduce the depth to 4 cm, that is minimum. This is extra-oblique, inter-oblique and transverse abdominis muscle, 3 muscle layer. You can see easily. These probes are easily available in gynecology, so you can use it to give tap block in your LSCS patients. So this makes your job easier to give tap block in LSCS patient, and they will be very happy when you give tap block. Patient will be very happy. So again I will show how to keep the probe and how to give the block. So here you can see I have kept the probe just above the iliac crest. I will go again in plane. I will insert the needle and see on the screen how it is seen. So after inserting the needle, you can see my needle is coming in plane, going through the external oblique, then through the internal oblique, and you can see I have reached there almost, and I started injecting the drug, and it is spreading nicely in the tap plane. So this is how you can give it with curvilinear probe, which is available everywhere. Dosage, as I said, with ropivacaine 0.2% 20 ml. Bupivacaine you can use 0.25% 20 ml. So if you want to give bilateral tap block, you have to make 40 ml and give the block. So to conclude the talk, choose your block wisely according to the type of surgery. So where there are various type of tap block and you have to select from that. Tap block is part of multimodal analgesia. It doesn't cover visceral pain. You have to supplement it with NSAIDs or paracetamol or tramadol to complete the block. These are high volume block, especially when you are using for laparotomies with incision from Zifi to the pubis, because you have to give bilateral tap along with bilateral rectus sheath. So you will require roughly 70 ml of LA, 20-24 tap and 15-15 for rectus sheath. So what I do is I take 0.75% ropivacaine 20 ml, I dilute it up to 70, so 20 ml ropivacaine, 50 ml saline. It makes my 70 ml of LA. It is roughly 0.2% ropivacaine, and I used to give it bilateral blocks. So this is how you can give the tap block. This is my YouTube channel, as you know, and now there are 150 videos, and this is 150 first video. So now we have 151 videos, and these are block videos and some presentation video. Hope you like it. Please share it with your colleagues to spread the knowledge. And this is my website or blogspot on that is anestesialearning.wordpress.com, where I uploaded some of my articles and some articles from my colleagues to share the knowledge. So this is all about it. Thank you very much.